So we're gathered here tonight, and we will be sharing this with other people who weren't able to be here tonight. I know there are some people who said they would be here, and maybe they'll still get here. And also, so I'm Joan Goddard, and I want to, as most of you know, I think we have a wonderful person to help us with answering our questions and give us information. And also he sent the links that you got in multiple times in emails. So hopefully some of you have been able to read at least some of the things that were linked in the emails. Greg Miller is a retired hospital staff RN, and he's been active in the California Nurses Association and the movement for healthcare for all for 35 years. Most of us hadn't even heard about it 35 years ago, but even if we have been active for 20 years or whatever. So Greg has helped to lead the Santa Clara County Single Payer Healthcare Coalition and our many years of public education, including door-to-door canvassing and sharing information and programming, public programming. We want to hear from Greg, and also he wants to hear our questions, so get your questions ready. But Greg, why don't you start us out with some introductory information? Thank you.
Okay, great. Thank you. Thank you for having me here tonight. And can you hear me okay, first of all? We had a few technical problems, and so I'm talking over a phone right now, so it's maybe a little not quite as optimal. So anyway, because I've worked as a nurse in, I guess you could call it the belly of the beast, when you're talking about a hospital staff nurse position that I had for a long time, you know, and I'm also a union member, an active union member. So I appreciate that we have a contract, that we have regulations, but we know that the only way they really make any difference is if we have to constantly struggle to make sure that they are followed. The hospital administration actually does what the contract says or what the regulations say. So that has sort of been, that's always been an issue, right? In other words, and I understood that the motivation of the hospital administration is largely about money and making sure they have enough money. Well, now it's, you know, when you consider if it were a nonprofit, a truly nonprofit entity, that might be somewhat acceptable, right? If they weren't out for really making a lot of money, right? And they are, of course, I worked for one that was connected to an insurance company, so that meant that they were, that was another problem. You know, the insurance, when you link insurance, private insurance, the private for-profit insurance to the healthcare, again, it's they make money off of actually delaying or denying healthcare. That's how private insurance works, right? That's how it makes money. So that is why, you know, that's why I see how it's the healthcare system serves us so poorly, right? Is that whole profit motive that you keep running up against, and that's what, you know, so that was my experience, right? Day after day, it was a daily thing to say get enough staff or to make sure you had the supplies that you needed and things like that. So that's sort of where, and of course CNA, of course, has to analyze what's the situation and educate our members about how this really works, right? Why we're, you know, what we're up against and how to deal with these issues all the time. So, of course, we looked at the big issue, right? The big issue, you know, how the healthcare system overall is run, right? And so that's where we got into advocating for a single-payer healthcare system, a system where a government entity pays for health care, and the profiteering is curbed. In other words, that's the key thing that we have to do to fix our healthcare system, is to get the profiteers out of it. We go into healthcare because we want to help people, we want to serve people well, we want people to be healthier, and that is always, the profiteering is always the stumbling block. If you want to look at it, maybe oversimplify it a little bit, but yeah, that is sort of the main stumbling block, the profiteering that's built into the system. And even Medicare itself has, over time, has been, we say, corrupted by, the introduction of private insurance, and not allowing Medicare to negotiate prices for prescription drugs, things like that, which are just sort of obvious problems that should never have happened, right? Anyway, so let me go start with, I wanted to start by talking about AB 1400. Even though AB 1400 is no longer a bill that's moving in the state legislature, it didn't pass the assembly on January 31st, so therefore it died as a bill. But I think it's an excellent bill, and I think that whatever gets proposed next time around, talking about like next year in the legislature, will be something very similar, because I think the bill itself is very good. Also want to just mention that there is a federal bill called HR 1976. I'm not going to focus on that as much. The bill is very similar in sort of its basic concepts and how it restricts the profiteering and what it provides people, with the benefits that it provides. So I'm just going to focus on one of them tonight. And HR 1976, of course, is not currently moving very well in Congress, given the current state of Congress, right? It's not, it does have over like 121, I think, co-sponsors now, what they call co-sponsors in the House of Representatives. But in order to pass the House, it will need something like 218 votes or something like that. So it has a long way to go for that. So I'm going to focus on 1400, and maybe if we could start that, do the screen share thing, and Rowan has thank you. This is a slideshow that was created for AB 1400, and so that's the focus of the slideshow. Those three things: what's wrong with the current system, what is CalCare, and the plan to pass CalCare. Okay, so the problem is that the first problem is that it's not universal. We have 3.2 Californians, or almost 88% of the state, are uninsured, meaning they would have to pay out of pocket for any care that they get, something most people can't afford to do. Underinsurance people with health insurance can't afford to use it because the copays, deductibles, co-insurance are too high. As many as a third of all insured Americans report delaying or skipping a doctor visit or necessary care because of cost. So, just because you have, and you can say, oh, I have blank insurance company, it's not, coverage is not the same as care and true access to care if you have to pay more out of pocket when you actually need the care. So our healthcare system is absurdly confusing, multiple options and levels of coverage, and there are hundreds of different plans. Even on Medicare, as it exists now, you have different Part A for hospitals, Part B for doctor's visits, Part D for prescription drugs. Each of those parts doesn't cover the full cost of care. So you often have to factor in supplemental plans and then Part C plans that replace some or all of the other parts. Most of these complexities are due to the fact that Medicare is trying to accommodate the profit imperative within our existing system. Both CalCare and Medicare for All nationally would simplify the system and guarantee comprehensive health care for all. Third problem is that American healthcare plans tend to omit critical health benefits. For example, most plans won't pay for dental or vision care or hearing aids without a supplemental plan. They also often don't pay for long-term care, which is going to become more and more of a problem as more seniors require it and as more people come down with symptoms of long COVID. Even when a benefit is covered, insurance companies can act as gatekeepers by determining that a procedure is unnecessary. Even if a doctor tells an insurance company that a procedure or medication is medically necessary, the insurance company can still decline to cover it. So all that, you know. So problem 4, narrow and restrictive networks. There's a basic lack of freedom. Typically, health insurance plans will only cover certain doctors and hospitals in a given area. If you go to an out-of-network doctor or hospital, you have to pay for most, if not all, of the cost yourself. We have no true freedom under our current system when our healthcare decisions are made by insurance companies. Another problem, it's too expensive. We spend at least twice as much per capita on healthcare as most other industrialized countries in the world, which guarantee healthcare to their people. Premiums are increasing at the rate of 2 to 3 times faster than our paychecks. Deductibles and copays continue to make care too expensive even for people with insurance. And of course, there's high prescription drug costs. There's sort of the Medicare Part D Act that was passed in 2003 sort of allows them to charge what the market will bear, basically. So which means they can really gouge us. And there have been some famous stories of like insulin going from $100 a vial to $500 a vial overnight. So those kinds of abuses exist under our current system. So the system has failed. Its medical debt is the number one cause of bankruptcy in the United States, and worse health outcomes compared to other countries. Lower life expectancy, higher infant and maternal mortality, higher rates of chronic illness than comparable countries. So why do these problems exist? 2 basic reasons: fragmentation and the profit motive. Different insurance plans cover a different set of benefits and pay for a different percentage of those benefits. Different insurers will often only pay for care if it's given by a provider in their network, and different payers have vastly different networks. The result is a complicated mess of a system that demands an even more complicated bureaucracy to keep track of it all. 1 in every $3 spent on healthcare is wasted on bureaucratic bloat. That doesn't include what's spent on advertising, CEOs' salaries, political donations, to oppose Medicare for all, things like that. Greed and an insatiable need for profits defines our healthcare system. The profit motive creates an incentive for insurers to deny care to patients. Their very business model is based on maximizing their profits by denying care to patients. So we have introduced CalCare AB 1400, the California Guaranteed Health Care for All Act. It was introduced by Assembly members Clara, Alex Lee, and Miguel Santiago back in February of 2021. There were 20 authors and co-authors, and the sponsor of the bill was California Nurses Association. So what is CalCare and how does it fix our system? First, the bill would guarantee universal coverage to all Californians as a human right. The 3.2 million Californians that are currently uninsured would be covered with the same series of comprehensive benefits as everyone else in the state. This includes the undocumented, the unemployed, and those who otherwise have a hard time affording health care now. Second, the bill would implement a single public program, CalCare, that would pay for all necessary and appropriate care for California residents. In other words, a single payer for health care in our state. This would eliminate much of the bloat and inefficiencies that plague our system. By not allowing private insurance companies to compete with the single payer, you can streamline the system and save billions every year in costs. Third, the benefits package included in CalCare is truly comprehensive. Unlike most current plans, dental, vision, hearing aids, and long-term care would all be fully covered by CalCare as part of a single comprehensive benefit package. Fourth, when it comes to receiving care under CalCare, people will be free to choose the doctors and hospital of their choice with no narrow network. True freedom in a healthcare system comes from being able to decide for yourself who and where you get your care from. That freedom doesn't exist under our current system. It will under CalCare. Fifth, under CalCare, care will be free at the point of service. Under AB 1400, there is no cost sharing. There will be no copays, no deductibles, no premiums, and no prior authorizations for care. When you need treatment, you go to your provider and get the care you need. It's that simple. This will remove many barriers to care that exist under the current system and will eliminate underinsurance in California. 6, the transition to CalCare means the end of the private health insurance industry as we know it in California. And while we certainly won't miss it, we do want to ensure that this transition is a just transition for the workers who may be displaced or otherwise affected by this change. For the first 5 years of the program, at least 1% of the entire CalCare budget, which means billions of dollars in funding, will be set aside to help those whose jobs are affected by the switch to CalCare. That could come in the form of wage replacement, tuition payments, priority hiring for people who want jobs in a new system, or early retirement, whatever works best on an individual basis. And finally, CalCare would mean that patient care is based on patient need, as opposed to the industry practice of letting the profit motive determine care. CalCare will eliminate for-profit insurance companies from controlling our healthcare system and will also remove the incentives to provide less care that we talked about earlier by changing how we pay doctors to a new system that is fair and puts patient care first. Additional highlights are that CalCare would ensure that, AB 1400 would ensure that CalCare funds go toward healthcare and not things like profit, marketing, political donations, or excessive CEO pay. CalCare would also ensure that rural and safety net hospitals have the resources they need to stay open. CalCare has a special projects budget specifically for the construction, renovation, or staffing of healthcare facilities in rural, underserved, or medical shortage areas. So single payer saves money. Multiple studies show that single payer systems reduce overall healthcare costs. An analysis from the Political Economic Political Economy Research Institute in 2017 showed that a statewide single-payer healthcare system in California would reduce net overall costs by 8% relative to the existing system. It would also reduce administrative costs. It eliminates insurance CEO salaries and profits. It cuts the big advertising budget, negotiates cheaper prescription drugs prices, and guarantees primary care and preventive medicine. Next slide, please. Financing options. So this is there were Assemblymember Clara introduced ACA 11 to deal with questions from legislators on how how would this bill be funded. AB 1400 was a policy bill, and that didn't have it had some general statements about funding, but it didn't get into enough detail for a lot of people. So he introduced ACA 11, which is as long as we don't have a policy bill to pair with it, it's not going to really happen until next year either. But well over half of all direct healthcare spending in California is publicly funded. And spending by the federal government on public health care programs like Medicare, Medi-Cal, and the Affordable Care Act represents close to 40% of all direct healthcare spending in the state. To capture federal healthcare dollars in a state single-payer system, states can obtain waivers for administering healthcare programs paid for with federal funding. To fully fund the CalCare system, the state will need non-federal revenue sources to replace the enormous premium deductibles, copays, and surprise bills that individuals and employers are now paying. Assembly Constitutional Amendment 11 offers a progressive taxation plan to fund comprehensive universal health care coverage and a health care cost control system as outlined in AB 1400. So you see there were 3 taxes proposed in that bill. These are not, the idea is that they're starting point for negotiation. Really, it's not these are not like set in stone, and of course they are, they're somewhat negotiable, and there might be maybe other different taxes instead of these. So, but they are. We try to keep them as progressive as possible so that the wealthy pay more and the middle class and poor pay less. And as you can see, they are structured that way pretty much. And just remember that these new taxes, replace all those premiums, deductibles, and copays that we're currently paying. So it always has to be emphasized because they always, the media, one of the opponents love to say that there are all these new taxes, but the taxes replace the private taxes that you're paying right now to the premiums and deductibles and copays. So single payer is popular. In California, a recent poll showed that 67% of likely voters support a single payer system. Among Democrats, that goes up to 85%. The support among Democratic voters is significant because Democrats are the majority in the state legislature. So there is massive support across the state and even across the political spectrum for guaranteed health care for everyone. So we've had, in our effort on our organizing for AB 1400, we've had different approaches. We've had a lot of car caravans and other days of action around the state, and that it passed the Assembly Health Committee and the Appropriations Committee, but didn't pass the Assembly. And these are other, yeah. So that's, yeah. I guess we could just go on to. I just want to mention that one sort of way we were organizing for this in the time of COVID was to because we didn't have a lot of in-person events. Is that we had a text banking program, text from home program, where we identified 50,000 new supporters of CalCare. Then once we identified the supporters, we had phone banks, which asked them to sign a petition online and make a phone call to their legislator. And so that was sort of the the method we used to organize people. And of course, we also had parties for sending postcards and letters, and we had other things too going on. But those are that's so some of the methods that we used. I think let's just go to questions right now. And let me just say I want to say we have locally we have the Santa Clara County Single Payer Healthcare Coalition, which is a coalition of organizations, people working on passing legislation and winning a single payer system at the state and federal level. And we have Facebook, as you can see, Facebook and Twitter pages, SCC Single Payer, and also an email address. And also the previous slide has my email address, which I would, you can contact me if you have any thoughts, ideas about how we could organize better. We do have monthly meetings on the third Tuesday of the month at 7 p.m. typically. The next meeting will be on Tuesday, March 15th. Also, you can see there's a bit.ly there for signing up. We have some new participants too. So I'm open for questions now. I think it's best we need to get on to the, people have the opportunity to ask questions.
I just wanted, this is Joan, while you're getting your questions together, I just wanted to say that the postcards, Greg just sort of mentioned the postcards. There were thousands and thousands and thousands of postcards specifically targeted to health committee members who were wavering or not supportive or whatever. And there were 3 designs, and we got a list, and I did 20, and the names were all practically the same in the alphabetical order. There were so many total that any one group of 20 was, just like all of them started with CO or whatever, something close to that. So do you have some questions ready to ask Greg, or things that you wanted to share from work that some of you have done work also, like I just shared. As we said, I think Lisa and Judy got on after we said that this, of course, as you know, is recorded, and we'll be getting the word out to the people who weren't able to be here tonight. But do you have any questions for Greg from, maybe start with the things he just presented, and then we can go to general questions? Other questions? Actually,
this is Greg again. I'm sorry. I did want to say a little bit about, maybe before the Q&A, about, where do we go from here?
Yeah.
And, what we learned from our failure to pass a bill, right? To get the bill passed in the Assembly and move the bill forward. And one thing I think is that we need to really do a lot more outreach to the public and get a lot more people involved, and also a greater understanding of what single payer is, because as one of the people on the call, who participated in the call after the bill didn't go forward, mentioned is a lot of people they say they're for single payer, they're for Medicare for all, but once if the opposition makes one of their typical arguments, which a lot of times are, misrepresent what we're talking about, or, they don't, they sort of don't understand enough about the system to sort of, to continue to support it. And that's definitely something concerning. In other words, we need to do a lot more education of the public, more outreach to people, explaining what we're talking about, and getting more people involved in the movement, actively involved in the movement, and to inoculate them. We need to be going to more like community organizations like WILPF, of course, and union locals and small businesses, churches, all sorts of different organizations and outreach to make so that people have a deeper understanding of what we're talking about. And also there was in this call, this follow-up call that they had, people talked about the idea of a ballot initiative, and really ultimately we'll come to that. I mean, no matter if they pass something in the legislature, the industry will surely respond by trying to put something on the ballot to defeat it, or we might do a ballot initiative, right? So that's a huge undertaking, and for that you do need organization. You need a lot of money for that. That's one reason we don't, just sort of do it easily. We don't easily go in that direction, but we need to be ready for it. We need to have enough of an organization and money behind to be ready for a ballot initiative one way or another. Another thing is supporting corporate-free politicians that won't take, that say, we do have a program at our local level where we have endorsed some local politicians that are running for office, and one of the things that they had to do to get our endorsement was to say, I will not take money from any healthcare corporations. So that's important. And also town halls. Another thing that you should know about is there are Healthy California for All Commission that is currently meeting. It's been meeting for over a year now at the state level. This was set up by the state, by the legislature, and they're having their final meetings now and coming up with a report really soon. They're going to have, I think they're one of their final drafts will be discussed, I think, on next Wednesday, February 23rd at 9 o'clock. If you do a search for Healthy California for All Commission, you can find out, if you want to attend. We encourage people to attend and, of course, advocate for a single payer system. So, and of course, there's things like letters to the editor and writing articles, and there's so many things that you can do. So anyway, I just wanted to mention that we are, of course, talking, there's different ways that we could move this forward, and I'd love to hear if you have some ideas about that too, besides questions.
Yeah. So I love that we're talking about single payer and not Medicare for all, because I think Medicare for all is just really confusing because of how much Medicare does not cover. Mm-hmm. And I see a lot of stuff here about long-term care, but I don't see anything about in-home care. And as a disabled American, in-home care is something that I care about. It's not just enough to put me in an institution. I have to be able to get support in my home, which Medi-Cal has and Medicare does not. And I'm old, so I'm on Medicare. So it's important to me that Medicare for all is better than Medicare.
Yes.
Right. So this is definitely is in both bills. The long-term supports and services access for everybody. For elderly and disabled folks, right? That's definitely written in the bill. So I don't know, I guess neglected to emphasize that, but
it includes home care, not just institutional care, which is what Rowan was asking about, I think. Yeah.
And yes, I did read the material ahead of time, and in one place it mentioned home care, but most of the time it just talked about long-term care, and I can't emphasize how uncomfortable that makes me.
Right. So we need to make sure it gets clarified often.
So you'll have the option for care in the home, or if you, whatever, in some kind of institutional setting, although of course most people don't want to do that, understandably.
Yeah. So are we ready for Paula's question? And just make sure you get your questions together, people, and get your hands up unless you need to put something in the chat. I'll try to watch for the chat too.
So Greg, this had lots of data and lots of stuff at arm's length. What I'm really wondering is, how will this work? Will people get a card? Will all the doctors, will they all be paid from some entity?
Okay, so everybody gets a card. That's right. You go to any provider of your choice. You get comprehensive health care, no copays, no out-of-pocket costs, all that, right? That's sort of the basics of the system. So how it pays for it is in the bill. There are two basic ways, I guess you could say. One is through using the current Medicare fee-for-service as sort of a starting point, right? Whatever Medicare pays doctors and hospitals for particular services or procedures will be a starting point. Or the other that's one way. Another way is through what we call global budgets, and that is really that's a very innovative thing that I think is what in terms of paying for care at an institution, at a hospital, at a clinic. What we will do, what both bills talk about is there's a negotiation. There's a negotiation between the system, the CalCare system or Medicare system, if it's the federal level, and the hospital. And if this happens at least once a year, and it actually can be renewed like quarterly. Okay, so can you actually, there are things that things come up, expenses come up that are unanticipated, that kind of thing. So what happens is that the hospital comes with a list of everything they need, all the everything that they do to provide healthcare, the cost, right? Whatever they need to whatever money they need to pay for the care that they give. And it has to be the care that they give. In other words, it includes the cost for their staff, their equipment, their supplies, their everything that they need to function and to do a good job on providing health care, right? So so they have to come and meet with the system, with the CalCare representative, right? Represent the board, and these would be probably set up at regional levels in the state, right? It's not just one for the whole state. It'd probably be several, bunch throughout the state. And this is the process that would go on for paying for care by hospitals. They would not be able to include profits or advertising or marketing or things that that they currently spend a lot of money on. And there is another option that's also written in the AB 1400, is that if you have like a physician group that could also be a negotiated, salaries could be negotiated, say for physicians. In other words, like say you have a group of physicians and okay, so, they're saying we need such and so much money to live or to be, to live well or whatever as physicians. And, and we want the system to succeed. We don't want to shortchange people or make it so that it's sort of, the people will just want to throw up their hands and leave or anything like that. We want the system to work. So it has to be reasonable, right? Both sides have to be reasonable. But the thing is, what we're doing though in this whole process is getting rid of this whole of the profiteering and having ways to eliminate the profiteering. And of course, the prescription drugs is part of that too. And also the purchasing of equipment is also something that's a negotiated process. We sit down with the pharmaceutical companies and say, okay, how much does it cost for you to produce these drugs? We will pay you for that. We'll pay you. That's what we'll pay. That's what we're going to pay you. Anyway, that's sort of the sort of key concepts. I don't know. Did I answer your question?
Yeah, that's what I was going to
Well, yes, and I noticed in the Q&As that you put the link out for. I read some things about rural doctors and primary care doctors not getting paid. But my question is, when CalCare becomes a reality, what will motivate the highly paid specialists under the current system to continue practicing?
Well, they're going to get a sort of a guaranteed source of income, first of all. I mean, like right now, there's going to be a big demand. The demand for healthcare is going to go up, right? There's going to be a lot more people needing healthcare and actually going and getting it, right? So there's sort of an assured demand and also an assured system of payment, right, from the government entity, the CalCare system or the Medicare system. Which is really an important consideration. Doctors right now have these staff. They have to employ like a whole regular staff of people to talk to insurance companies and bicker with them about, we need this treatment and why aren't it is a necessary treatment. Why? So all this kind of thing they won't have to waste their time doing that. So that's something to really consider. So I mean, I would say maybe the very highly paid specialists might not be getting quite as much money as they are now. And on the other hand, we would want to, the system, we would try to encourage people to go into primary care and pay them a good salary, right? So it would be more, I would say, a little more equalizing effect on these salaries in terms of the primary care versus the specialist care physicians.
Yeah. When I was reading through the frequently asked questions that you sent us the link for, I think that was where I saw something that made me think that the primary care physicians, are in more demand almost now because these specialists can charge more, and somehow the insurance companies think that they should get more. And yet I was thinking specialists specialize. They don't have to keep track of every blinking thing about the body like the primary care physicians do. So we need to value them more. I see that Karen has her hand up. Are you ready to ask your question, Karen, after you unmute?
Okay, so right now in the current system, you go to a doctor, your primary care physician, they refer you to someone. You have to get that approved. When you go to that doctor, he may have you have to go through some procedures that has to be approved. So when you're in this new system with single payer, and how do you, without things being approved, how do you protect from fraud? How do you know a doctor or a system is not doing fraud and collecting money on things that really aren't being done? So how do you do that where how's the oversight? How do things get done to protect the system from doing fraud?
You do need to have, I mean, just a sort of a common sense thing, I guess, is that you would see that if a doctor is doing all, prescribing all these things or requesting payments for, say, X number of visits, and it's sort of out of line, right? If it seems excessive just on the face of it, you would go and look into that further, right? You would say, well, are you really seeing 500 patients in a week, or
it can be more subtle than that, though. It can be much more subtle than that. They can, there's people who con people all the time. So it doesn't have to be excessive patients. They could just do procedures that isn't obvious. So if there's no oversight, there's no approvals, there's just people who can figure out schemes and scams all over the place. And, there isn't beyond a doctor to be a con artist. They figure out how they can get more money. So, and I just wanted to know, is it built into the system that there's oversight?
Absolutely, there has to be that kind of with any system, right? With the current system, right? They look for that kind of fraud, right? We have to continue to really make sure that, to have some kind of enforcement or some kind of mechanism to detect fraud.
Yeah.
And Medicare probably does that now. Not just the insurance companies, but Medicare.
They do. There've been a lot of, they've fined some of these big corporations for defrauding Medicare. Like some of these, like the Hospital Corporation of America, I think I'd had to pay several $1 billion penalty for some kind of fraud scheme that they had. So this does happen on the current system, and it's something you have to watch out for. I mean, as long as we have a system of the capitalist system, basically, that really encourages people to sort of just make money at other people's expense, you're going to have this kind of activity going on, and you have to. That's the way it is. This current system is not about serving the people, right? It's not about So, and that we want it to encourage that kind of mental that sort of mentality in people, but that's a long-term process.
Yeah. So Judy has a question. Peace Worker has a question in the chat. Did you want to? I think I saw that a while before Paula put her hand up again. So Judy, do you want to reword or add to your question that's in the chat about it's a different angle that you're thinking about, which is working this through the legislature.
Yeah. Well, the problem dealing with the huge corporation of healthcare and the medical associations that doctors belong to, and their relationships through the hospitals they practice in, and the variety of referrals. There's so much infrastructure, if you might say, that we have to fight. And legislators, of course, get lobbied. I sit up and watch things late at night on TV, and it's all ads for drugs and for old people, for young people, which have these horrible, statements of what else can happen after you take this drug. You could die, for example. So how do we fight that advertising campaign, the corporatization, and the lobbyers? We're just little people, and no matter how many postcards we write and how many vigils, this is a question for everything we work on as social activists, justice activists, is how do we get big enough, loud enough, without being violent, to change the system? And that's a global question, I guess I'm doing.
That's what I was alluding to earlier, is that we need to do a lot more outreach and getting people involved in the movement. And education is part of that in terms of just answering these questions that people have. We have to, and to sort of counter the misrepresentations that the media will put out there. Of course, the media, you understand, the media gets huge advertising from these healthcare corporations, right? The insurance companies. They buy all these big ads in the Mercury News and on TV, and as you were saying, all these different new drugs that a lot of times are actually aren't really. They change slightly. A lot of times, in other words, to preserve their patent, they change an old drug slightly and create something that they can say is new. And then they say it's new, improved, and everything, and it doesn't really. So they advertise it, and they try to get people to think that it's something that it isn't. But and actually, the fact is that most of the breakthroughs in terms of medications are actually developed through government funding, not through the pharmaceutical company R&D, and that needs to be appreciated by people. We need to explain that to people, because that's another one of their arguments. They say, well, if these pharmaceutical companies don't get this money, they can't do R&D. Well, the most important R&D is done through government grants and through universities or government institutions, and so that's just another thing, another misrepresentation that's out there. But it's basically it's the problem with the media. The media as a whole, they misrepresent what we're talking about. They say that it's it's going to cost it's going to cost so much more, and it's going to be all these new taxes, and they fail to mention that the current system is way more expensive than anywhere else in the world, and it's actually. We actually, in California right now, we spend $517 billion a year for healthcare. They usually don't talk about that when they talk. They like to talk about it's going to cost $400 billion, but right now we're paying $517 billion. So there again, it's a savings, right?
I've thought of an action that I probably don't have, if you'll pardon the expression, the balls to do, and that is to dress up with a briefcase and a nice outfit and go to a doctor's office and say I'm representing blah, blah, falsely, and get in there and open my case and show them apples. And then get the bum rush for impersonating, because it's just a way of, maybe we could do something like that on street corners. This is about what you get without bankrupting yourself if you become ill or injured, free
from
the healthcare system. Here's an apple.
Right.
But I'm not in the street theater like the raging grannies are, so that's a suggestion, perhaps.
But that's definitely a really good thing that we need to somehow learn how to do. Of course, there again, you need to also have a connection to the media so that you get coverage of your action.
Well, yeah, and if you go in with a news camera crew, but people can put their cell phone in a pocket and somehow, I don't know how it would be done, but maybe 60 Minutes will do it for us. They're always barging in, and they're the media.
That's a good idea.
60 Minutes is not pure, of course.
Put it in their ear.
Yeah.
Right. Yeah.
Well, maybe I'll write to whoever one writes to there.
Yeah, cool.
But that's what you're suggesting is really one of the things that we need to do much better is sort of these very imaginative actions. I remember Michael Moore and his movie Sicko. He was very good at that kind of stuff.
That's true.
Right.
Huh.
The other thing I was thinking about is that we, when you were talking, Greg, about doing public education, in addition to this kind of creative and eye-catching and media-worthy, et cetera, thing that Judy's talking about, which is great, the idea that for a long time, we've had public programming about single-payer healthcare, and we've invited people to come to a meeting, to a building at a certain time. And I crossed my mind while you were talking about some things that we need to go to their organizations. And we've done some of that, but we need to really focus on going where they are rather than thinking they're going to come to us. And I see that Paula has her hand up again, unless you wanted to say something about that, Greg. Sorry.
Oh, we need to set up appointments now in the age of COVID and Zoom. We have to set up somehow try to set up appointments or this kind of event, instead of in a live event. Unfortunately, CNA, they're very very careful. Understandably, as nurses, we always emphasize the safety of the nurses and the patients, right? And the importance of going to the max in terms of following maintaining safety and not jeopardizing people. And so for that reason, they've always been more leery than many people in our movement, right, about doing in-person events, going, and of course, so in this day and age, we need to do Zoom events, in order to talk to people. But it does make it more difficult, right? In order to it makes it more difficult in certain ways, anyway. Zoom is helpful in some ways because people can attend without going anywhere. They can stay at home and be part of a meeting, and that's definitely a good thing,
right,
for a lot of people.
Right. So we need to find out what I guess I was trying to get at was that we need to think of all the groups we possibly can and find out who knows people who are in those groups and how do we get to have attend one of their sessions or whatever. But Paula had her hand up again.
Yeah. So Greg, it's been a couple of weeks. I guess January 31st was the vote and it did not pass in the assembly. Is that right? Okay.
Right.
So in that 18 days, in the time of reflection and the success to get it as far as you got it, what will you do differently next time to get it to pass?
I guess what I was sort of talking about earlier about what my opinion is that we need to do much more effective outreach and education and get more people involved, and letters to the editor, but create the consciousness out there. That's the basic thing. I never did touch on that day of January 31st, which was something that was controversial because
Greg, when you do that, could you also contrast it with the success in the health committee meeting because of all that outreach that was done with a very small number of people, but some of those people reneged on the 31st. So I'm sorry to interrupt, but it seems like there was a contrast there.
Yeah, we did make progress. I didn't really go into it, and I want to, is that, we were making progress really in the assembly in the sense that Jim Wood, the head of the Assembly Health Committee, came on board to support the bill. before he had been an adamant opposition, and that was important. And also Rendon, the assembly speaker, also, once he saw the funding bill, the ACA 11, he allowed it to move forward in the assembly. So that those were important things, and a lot of it had to do with, there was a lot of pressure put on Wood in his district, in the sort of the north coast, like Sonoma County, and north of that is his district, and he had lots of people working on him. And but then on the 31st, there, some of the thing that was very controversial was that Assemblymember Clara did not allow the vote to happen. In other words, we didn't have, and CNA and a lot of people were very upset about that, because we wanted people to stand up and be counted. We wanted to see assembly members have, either say yes or no. And I think Cola's, apparently what he was saying was that it was far from, it was not going to succeed. It did not have the 41 votes that it needed. It was far from 41.
Right.
Nevertheless, we wanted to see who was voting yes and who was voting no, and people that had maybe pretended to support. At least we know where we stand, right? Type of thing, and we can sort of we have a better idea of who to, if we want to oppose people in a primary type of thing. That for them to actually for them to have the vote rather than have the bill withdrawn, which is what Assemblymember Clara did. He withdrew the bill before the vote happened, and that was very disturbing. And it was disturbing to especially CNA, because CNA is the organizational sponsor of the bill, and they were sort of like this was something that just happened on the spot that Clara decided to do.
Greg, could I also insert that I'm sure that Osh knows who the 31 people were who were going to vote for it, and who was still struggling to get their heads set on right, and who is just weird. So I think there's not really going to be a problem with trying to figure out who needs to be worked on.
Well, they all need to be worked on. I mean, even the yes notes need to be fortified, all right, and need to. I mean, that's what I think. I mean, it's the main point is that when you need the movement to be much stronger and vociferous, many more people involved. And that's where like if you sign up, by the way, I didn't mention that in the original thing that was sent to you for this meeting, there's a way that you can sign up to be on our mailing list. In other words, what you automatically get the single payer coalition's mailing list. We have we send out MailChimps every so many weeks, so you won't get a huge number. But the bit.ly 3IUV31D, that was in the original meeting notice. And so if you go there, you click on that, it'll be like it's like a sign up. It's like a form that you'll fill out. You just put your name, your email address, how you might want to be involved. Just to, a few questions like that. Like I think includes your zip code. So that we,
and the links are in the chat.
We know what.
If you want to save the chat,
yeah.
I've put all the links from his email into the chat.
I said yay, Rowan, but I was muted. I don't see anyone else with their hands up right now. So this is your last call for right now, but we obviously can keep talking about this both in the future because I don't know anyways near as much as Greg does, but I go to the meetings and I've worked on door-to-door work and a lot, you know, those postcards and phones and all that stuff. So you can start with me, and then, you know, we'll go to Greg and others who have more information if we can't figure it out among ourselves. Does that make sense?
Yeah. So like if you sign up to that bit.ly/3IU capital V 31 capital D. If you go to that and sign up, you will be on our. You will get notices about our meetings, and so in other words, you'll be sent the Zoom link for all of our monthly meetings, and that's one way you can get involved. I really encourage people to do that. And something else I wanted to ask you all is if you belong to an organization, another organization that you know, we could come to with with this sort of a presentation, something like this, to talk to people and try to get them involved in the campaign. We'd love to do that, especially talking about community organizations, churches, business organizations, if you have any connection to anything like that, because that's, I think, is a weakness of our movement, is that we could, if we are able to get small business support, this is definitely something that will benefit small businesses, because they will be ensuring that they and their employees will have health care. There'll be sort of a what they call like a it's sort of equalizing effect. In other words, everybody will have it. Everybody will have it. So it won't be like, you're this small business has, or people having to keep their job. That's another thing that we should always remember, is that, if it's not related to employment anymore, you don't have to stay in a job that you don't like, and you'll have freedom to actually do a lot of things that you can't do right now. And if you always have to work for this employer that you don't particularly, or you don't want to particularly want to work, and it'll free you to maybe start your own business or whatever. So, but small businesses, you can see from the tax structure that was proposed in the ACA 11, that they would not pay anything. They would not pay any. The gross receipts tax would only apply for gross receipts greater than $2 million a year. So, in other words, the truly small businesses would be exempt from that part of it. They would have to pay something for the other tax, the payroll tax, but it's, relatively speaking, it's much less than they would have to pay for, say, premiums to insurance, right, to pay for their employees' insurance type of thing. So anyway, small businesses, that's a key thing. I think that we need to do better outreach, because, it's a sort of strategic thing that the business community supposedly doesn't like this, but it's really the big businesses and Wall Street who are invested in these profiteering corporations. They don't like it, for sure. They will not benefit from this, but all the other businesses will. You'll be getting health care for your employees. It's much less expensive, and it covers everybody, and the people will be likely less absenteeism and that kind of thing. People are healthier. So that's just one approach. I think we need to really take. Wendell Potter was on our call, that follow-up call, and he was really there are some organizations that focus on small businesses that we need to really hook up with and see if we can maybe local chambers of commerce that are especially the ones that are not linked into the big corporations.
So Greg, if getting the message out is going to be the big thing that makes the difference, I'm thinking of the Poor People's Campaign, and that campaign in California has organized training programs to train people on how to talk about this and how to reach out. And I'm wondering if the California Nurses Association has something like that, like training a speakers bureau, or something like that. Do you have such a thing?
We've had things like that. We had like part of our organizing for AB 1400. They did have they had a district leader program. They had where people took responsibility for a particular assembly district and focused on, pulling together support for AB 1400 in that district and putting pressure on a particular assembly member. And they have a lot of things like that were for training people how to make presentations, and
good.
They do that. I mean,
because
that does exist. Yeah.
Because the message and the clarity of the message, you're up against these big lobbyists who have all this money, and if you're going to fight that message machine, you got to have your own really strong message, it seems to me. I would highly suggest a book called The Story Wars, which is the story of how the PR agency that brought. Do you remember the story of Stuff? 15 years ago, which was the story of Stuff, the little animated thing Annie Leonard did. Okay, those guys are socially aware. They're in San Francisco, and they wrote this book, The Story of Stuff. Here.
Annie Leonard. It's great.
Here it is.
Good.
And this is how to create a message. And the authors are, the author is Jonah Sachs, right? I'm reading it backwards. This is an excellent tool on creating a message. I mean, it's a how-to tool. Yeah, look in the back. This might not be. I have had several copies of this, but this is a toolbox on how to create a message. And you're up against the big guys.
Why do you keep saying you?
Well, this California Nurses Association is up against
It's us.
I know, but you're the organizing committee, just like the Poor People's Campaign has an organizing committee. The CNA has an organizing committee, and those organizing committees, I mean, you're fighting the big guys. You're really fighting the big guys. And it's a tough battle. Really tough.
So I'll look at that. I personally will check that out, that book, and
several of us
see what that say. What has that? How that? I mean, we have the people that were working on our campaign in CNA. We had about a dozen people around the state working on, paid staff working on this, and that's important. I mean, to have an organization that is dedicated to that, right? And I'm sure I'm pretty sure that they we're looking at all kinds of different angles that you're talking about, right? To creating the message. I mean, one thing we did learn, and we supported Bernie Sanders as an organization, and remember how he popularized the idea of Medicare for all. I mean, even though with the problem of saying it's Medicare for all, and all the problems of Medicare right now, and mainly the main problems are that it's been slowly being privatized. But anyway, he popularized the whole idea through his, campaigning, and then I remember working on his campaign here, for the presidential primary in 2020, and going door to door. That was a key thing. And remember how he did win this area, the areas, the districts in this area, because there were a lot of people doing door to door work, talking to people, and it's I'm sure that having been involved in the campaign, say back 10 years ago, his campaign bumped the percentage of people, of support for Medicare for all, like each time, I would say probably about 10%. That's off the top of my head in terms of amount of percentages, but it really did. He popularized the idea, right? So it's partly that, right? It's partly supporting candidates who are running on this and who we can trust, because they aren't, we have to do the research on where they're taking, you can find out where they're taking their money from, right? And are they, they can say, a lot of people say they're for Medicare for all, but you have to go and see where they're getting their money and judge from that. So
Yeah.
Locally, we're supporting 4 candidates. The coalition is supporting 4 local candidates on the basis of their advocacy for Medicare for all and some of the work that they've done, and also that whole issue of they are sworn not to take money from healthcare corporations. Those are Claudia Rossi, running for the County Board of Supervisors from the southern part of the county. Sajid Khan, running for DA. Peter Ortiz, running in District 5 for the San Jose City Council. And who's the other person, Joan?
Well, we first interviewed a young man.
Oh, Alex Lee.
Oh, Alex Lee, for sure. Oh, right, for the state legislature.
A competitive race to be, for his assembly seat right now. So we need to. So anyway, so we came out. We had an interview process and questionnaire and interview process, and those 4 candidates we're supporting as the coalition.
Yeah, there were 1 or 2 who said they were supporting it, but they clearly didn't know a thing about it, and they hadn't really tried to find out, even though one of them was a past member of the legislature who should have known or found out that he should have known. Anyway.
Well, some people are just sort of winging it, right?
Right, exactly.
They're totally faking it, right?
I do want to draw people's attention. I do want to draw people's attention, because we're going to need to stop before too long, unfortunately. I want to draw people's attention again to the frequently asked questions. And you'll notice when you go through that they refer to, I think it was HR 1384, which is probably the number that it had 2 years ago or something. It is, as Greg said earlier, 1976 now. It's a nice, interesting number, 1976. Not 1776, but 1976.
Think of some good things that you did in 1976, and maybe that will help.
Yeah, right. So I guess we have the last call for questions. The very last call, and we definitely can, if people think of questions, I think everybody has my email, and probably Rowan's and Paula's and other folks. Let's communicate. We know that the Nurses Association is extremely committed, extremely wonderful leaders, extremely knowledgeable, etc. But it really is up to all of us, not just CNA. They're the leaders and the organizers and so on. But we can all do things with our neighbors, our friends, our relatives, and anybody else. And it's not just California, it's also anywhere across the country, because at some point there's going to be a national bill, and those people we talk with across the country know somebody in California too. So it all comes around. Greg, do you want to say anything else?
The hope is that we can set a good example here in California that will just inspire the rest of the country, or to pass a national bill, or at least other states to pass bills. But just I want once again to say, mention my email address is brogregm@sbcglobal.net. If you have any ideas, and especially if you all have connections with organizations that we might go out to do speaking engagements, I would definitely appreciate that.
Great.
So it's brogregm@sbcglobal.net. It was in the it was in the
notice.
Right. We'll send it out. Oh, it was in the slideshow. In the slideshow. Yeah. And that'll be in the recorded version of this. Yes. That's great. So
thank you again for having me. And
thank you.
I really appreciate having this discussion with everybody, and just, I really feel like I'm, with the songs that you're singing, I know that I'm among friends.
Right.
In terms of single payer, and also being anti-war.
Yeah. Yeah. Definitely.
I'm an anti-war veteran myself. I'm a member of Veterans for Peace. Right.
We work with them here too. So let's see. We obviously, if anybody has any announcements, we need to know about that. So please put your hand up if you do. And I just wanted to say that I'm really glad that those of us who were able to be here tonight were able to be here and have conversation, or the opportunity for questions and so on. But we can keep working on this and talking about it. And also there are groups, as the Santa Clara County Single Payer Healthcare Coalition meets in San Jose at the Alma Street. Now I can't think of it, but it's right by the Tanyan railroad station on the other side of the river, on the west side of the river.
Hopefully sometime in the future, right?
Right. Right now we're meeting like this.
It's 525 West Alma Avenue is the address, but right now we're still meeting by Zoom.
Yes, definitely by Zoom. So you can contact Greg and you can contact me, and we'll see about getting you connected up for the next meeting. As Greg said, it'll be in the middle of March. The third Tuesday is the monthly date for the meetings. So
Rowan has her hand up.
Oh, very good. See, I didn't go over to the beginning of the list again, so I didn't see it. Sorry. Plus, it's against a white background. How are you?
Yeah, that doesn't help. So I just wanted to say that I've already put it in the chat, but I'll put it in the chat again. The Will San Jose YouTube channel. This recording will be there, but also we had, as National WILF US had a program for the Poor People's Campaign for our kickoff for our Solidarity Action, and the video for that and the promo video trailer are also on the WILF San Jose channel, because evidently National is having trouble uploading things to their channel. And so I said, I'll just put it on ours, and you can, get it nationally whenever you can manage to do that, so that we would at least get it out. So if you missed the amazing conversation with Reverend Theo Harris,
yes,
and the program, the testimonies by George Friday and Mary Bricker Jenkins talking about how we got involved with the Poor People's Campaign and all that stuff. It's really juicy, some great music, some great talk. It's on our channel. So
yes.
Please watch it.
And just think the people who find out about that from somewhere else around the country and tune into our channel, just think of all the other wonderful videos that Rowan has posted there from our past programs and otherwise that they'll get exposed to too.
That's my hope.
Great.
So.
I need to go, but it's been wonderful. Thank you.
Thank you.
Thank
And
you
Paula,
so
we
much.
need to give you credit for coming up with this idea. Yay, Paula.
Well, Greg, you gave us lots of information. Thank you. So I know more now than I did 2 hours ago, and that's great.
Yes. Thank you. Thank you.
Thanks.